So Phaco in myopic eyes and Phaco in hypermetropic eyes. So basically, see in Phaco in the myopic eyes, there are a few additional issues that crop up. You know, what is the best way to do the biometry? What IL formula one selects? And what is the IL power? Do we have to address the intraocular lens power? In addition to, you know, the surgical nuances and IL considerations for these patients. So the most important problem with these high myopia patients is the presence of posterior staph.
Short and long. Your topic, that topic was for the next session. Phaco and short.
Yeah. Okay, so okay, so I think there will be there is some overlap. I have started out that So this is actually see in myopic patients the most common problem that you encountered is a posterior staphyloma, as you see here, and many a time the fovea may not lie at the pit of the staphyloma; it may be lying on the wall. So how common is posterior staphyloma? If you see this particular study, as the axial length increases, goes to 33.5 and beyond, the staphyloma is seen in 71.43% of all the patients. So it is quite a significant problem. So if we are using an immersion ultrasound measurement, and if you are measuring up to, the bottom of the staphyloma, you're going to get an abnormally long axial length. So you should use a B-mode guided biometry if it is available in the B-scan unit, so that the A-scan is taken from the central vector axis. And of course, the best option would be to perform, an ultrasonic optical biometry for this patient. So because the patient fixates on the light, and you know that you're measuring the refractive axial length. So what are the formulas that are, popular for the extremes of axial length? See, for the routine axial length, any new formula is going to do well. There's not much of a choice for us. However, formulas perform less reliably at extremes of axial length. Short eyes, they overestimate the required IL power, resulting in a myopic error. Long eyes usually result in a hyperopic error. And these, these changes, these patients with high myopia or high hypermetropia are not very uncommon. See, less than 22 millimeter length patients, axial length patients are seen about 4 to 7% of the patients, and more than 26 millimeter axial length are seen in 8 to 6% of 16% of our cataract patients. So, if you are measuring the axial length using ultrasonic biometry, you have to use a if you are using these traditional formulas, Holiday 1 or Hygie's, SRKT, Offer Q, and if I measure the axial length using optical biometry usually overestimates the axial length. So you have to modify the axial length by a Van-Cock factor, and this factor varies from formula to formula. So you have to modify the axial length to get at the true axial length, and before you use the standard formulas. Now, if you are using the current formulas, these are the new formulas, so there you don't really need to make this Van-Cock adjustment, and you can use these formulas as such. So which are the good formulas for this? So, for example, this particular study published last year, where axial length was more than 28 millimeter, compared the Barrett Universal 2 EVO, Kane, HeLa, RBF against the older formulas, and found that HeLa, RBF and Kane formula are better choices for these eyes. And again, this is another formula, another paper which is just published in October. I mean, it has been published online. So they found out that again the Van-Cock adjusted axial length for eyes more than 25 millimeter, and the newer formulas, all the formulas have done quite well for these eyes. So basically, it boils down to, the use of newer formulas, and if you are not using the newer formula, then you have to modify the axial length by using the Van-Cock modification. So you get at the axial length, okay? And now the question of, what exactly the IL part that is to be used. See, after a scleral buckling, the axial length usually increases by 1 millimeter. Anterior chamber depth never changes. But since we are measuring the effective lens position based upon the axial length and the K reading, you get a lens which is sitting deeper in the in the eye, so which predicts a higher power. So this has to be taken into account. So if you're dealing with a patient who requests a IL myopia patient with more than 14 diopter, you need to reduce the IL power by a factor of 0.5 diopter. So this is about high myopia. And then now in the short eyes, the constants are a little different. In the short eyes, hypermetropic eyes less than 22 millimeters, the small axial length combined with high power can cause a large refractive surprise with a minimal shift in the effective lens position. And as I mentioned earlier in my previous talk, the tolerance for IOLs with higher power is higher. 30 diopter, for example, it could be it could be 29 diopter or 31 diopter. So that can also give rise to refractive surprises in the postoperative period. So basically, once you have got the axial length right, so which is the best formula for patients with an axial length less than 22 millimeter. So this particular, again, it shows that the Kane formula, Pearl DGS formula have done extremely well. So basically, you have to use an optical biometer to measure the axial length for these eyes and use a newer formula, Kane formula or Pearl DGS formula to get you the best outcome. So I think this is how, I tackle high myopia patients and, high hypermetropia patients in my practice. So thanks a lot for your kind attention.